morning, everyone. For some reasons, Professor Lee is unable to attend today's meeting, so I will be delivering this presentation on behalf of Professor Lee. I'm Chong Zhang from West China Stomatological Hospital, Sichuan University. So today I will introduce our novel reconstruction of orbicularis oris in unilateral complete cleft lip repair, and follow these 4 parts. So we know unilateral complete cleft lip is one of the most common congenital defects. Although primary reconstruction of UCCL is undertaken in initial surgical repairment, it often results in secondary deformities. And it is a significant challenge for a reconstructive surgeon to avoid the secondary deformities and to correct this defect in an optimal way. So we know the orbicularis oris muscle plays a critical role in lip and nose morphology, and the lack of the muscle continuum is one of the factors leading to labial and nasal deformities in UCCL patients, and even affects the canaloplastic scar. So based on the literature and our experience, bilateral cleft lip repair often results in good nasal symmetry. We proposed a novel surgical maneuver to improve the balance of forces of the orbicularis oris in the facial midline. And in our previous studies, we simulated the forces on both sides by computer. It was demonstrated that the width of the muscle and the distance between 2 angles oris points could influence the level of deformation and stress. So we carried out the novel reconstruction and evaluated the 1-year outcome of the novel reconstruction technique in UCCL patients. So in our study, we collected 14 patients with complete cleft lip undergoing canaloplasty between 3 and 6 months of age, and operated on by a senior surgeon from 2018 to 2019 were reviewed. And patients were chosen based on the following criteria: and without syndromes and high resolution quality of their pre-operative, 1 week post-operative, and at least 1 year post-operative photographs. And only the balanced forces technique was utilized for the muscle reconstruction. And the design of the cleft lip repairs follow a modification of Millard's technique. And for the muscle reconstruction, the novel surgical manual aimed to achieve equal torque on both sides of orbicularis oris muscle, with the fulcrum located in the facial midline. And the leftover muscle on the non-cleft side near the midline was used to fill muscle defects and rebuild the vermilion tubercle. At the time of primary repair, rhinoplasty was followed by procedure. And this is a video of the key procedures for this lower reconstruction. And we can see we'll follow the modification of the Millard's technique. Okay, this is the most important procedure in our reconstruction. We dissected the orbicularis oris by the deglobing technique and confirmed the locations of the inner base point of the orbicularis oris on 2 sides and kept the balance of force on both sides. As you can see, we dissected the cleft side muscle. And the rhinoplasty way carried out the Tajima procedure. And in the end, we sutured the both sides of the muscle in the facial midline. Okay, and in our study, we measured the 4 upper lip length markers and the 5 nostril length markers were identified in our patients. So the results showed that the horizontal lip length ratio did not change significantly after surgery, but was normalized to a ratio of 1 in the 1 year follow-up group. And after the surgery, the vertical lip head ratio, filtral head ratio, and lateral lip head ratio was changed significantly and were normalized to an approximate ratio of 1 in 1 year follow-up. And the nostril width could not be measured preoperatively in the UCCL patients, but the same trend was observed in the nostril wise ratio and the nasal base wise ratio, which normalized 1 year after surgery to 1.24 and 1.15 respectively. And the nostril head ratio was corrected to a ratio of 1.06 after surgery, and it did not change significantly 1 year after surgery. So according to our results, and we can see the novel manual maintains a good labial and nasal morphology in UCCL patients. And this is an overview of our patients with novel reconstruction. Okay, in conclusion, according to our results, the long-term surgical outcomes demonstrated that the novel orbicularis oris muscle reconstruction technique maintains labial and nasal morphology in a good state, and reconstruction of force balance plays a critical role in maintaining a positive long-term surgical outcome. And in the future, we still need to validate the effect of orbicularis oris muscle force balance on secondary deformities post-cleft lip repair. And this is our cleft lip and palate treatment team. And welcome to China and welcome to Chengdu. Thank you for your attention.
Thank you. Good morning, ladies and gentlemen, all dear doctor. Firstly, thank you for the committee for giving me the opportunity to delivering this topic. I am Dr. Manul Ayu Umburati from the Department of Dermatology, Venerology, and Aesthetic of Faculty of Medicine, University Airlangga, Dr. Sutomo General Academic Hospital from Surabaya, Indonesia. And this morning, I will deliver a topic about the role of probiotic in psoriasis. Okay. As we know, psoriasis is a chronic immune-mediated inflammatory skin disease, and it's thought to be the autoimmunity process in this disease. And the pathology of this disease is actually the interaction between genetic predisposition, immune dysregulation, and also the external factors from environment such as alcohol use, smoking, infection, drugs, and also trauma mechanical. In the world, the population of psoriasis patient is among 125 million in my country. The prevalence is between 1 to 3%. This disease affects 3.2% of adults, and in children is about 0.13%. This disease is not only skin disease, it also can complicate into systemic system like arthritis, cardiovascular disease, and also mental health, especially depression. From the pathogenesis of psoriasis, it definitely, the main process is dysregulation of immune process, where from the skin injury, a normal skin can develop or activate the dendritic cell, and where the dendritic cell will activate the cytokine. Cytokine will differentiate the naive T cell into effector T cells. The domination of effector T cell in psoriasis, especially for Th17, Th22, and also Th1, is the mark of the disease. And the inflammation, keratinocyte proliferation, angiogenesis, etc., it happened because of the pro-inflammatory cytokine produced by those T cell effector. And those inflammation and also keratinocyte hyperproliferation can manifest into the clinical lesion of psoriasis, and it can evolve into some variants of psoriasis. The most common form of psoriasis is psoriasis vulgaris and also scalp psoriasis, but sometimes we also meet the patient with pustular psoriasis. Now, psoriasis is also happening pretty much in patient, and when the common or psoriasis vulgaris uncontrolled and untreated, it could be affect more than 90% of body surface area become erythrodenic psoriasis. But something that we have to remember that psoriasis is not only about skin disease, because the inflammation is not only happen in the skin, but also in a systemic. So the systemic comorbidity is very common in psoriasis, such as arthritis, enthesitis, obesity, coronary heart disease, Crohn's disease, and also diabetes mellitus. The theory of gut-skin axis is well developed in the last decade, I think, where this theory stretch out where the gut microbiota population, where we know in our gut is living microbiota with their own homeostasis composition, and those homeostasis can be disturbed by some factors like diet or disorder of sleep or any kind of lifestyle, health status, and also medication. And the disturbance of the composition of the gut microbiota will decline the microbiota metabolite, especially the butyrate or short-chain fatty acid, and it will disturb the function, the regulation function of SGFI itself. It will not inhibit the Th17 production, and also reduce the ability of differentiation of Treg. So this condition will then promote the low-grade and chronic inflammation and also damage of intestinal integrity. Because of this damage of intestinal integrity, it's possible translocation of many antigen from the intestinal or gut into the systemic system, and then it can reach the skin, and it will respond by skin immunity and precipitate the psoriasis lesion. Talking about microbiota, maybe sometimes we have been confusing about the term of microbiome and also microbiota. So maybe I can say that the microbiome actually refers to the whole microorganism, their genome, and also their environment. But if we say microbiota, actually microbiota is the microorganism community that live inside the host, not only on the gut, but also it exists on the skin or saliva and cavum oris and etc. Talking about gut microbiota is the microbiota community that live in our gut. This is the largest microbiome in our body. And actually the physiologic function of the gut microbiota is to ferment the food into beneficial metabolites, especially the short-chain fatty acid. And this short-chain fatty acid is very important for our cells, our body. It is a source of energy of the cells, promote gut barrier integrity, and also stimulate T cell regulator who have a very important role to keep our immune system in homeostasis. And the dysbiosis condition is the distortion of biodiversity and proportion of the microbiota. In a gut, we can see in the dysbiosis condition that the pathobion is the bacteria, that pathogenic bacteria grow excessively, while the commensal bacteria decrease, and also the diversity is disappearing. So some previous studies has been confirmed that the gut dysbiosis also relate to some disease such as cancer, metabolic disease, infectious disease, and also some autoimmune disease such as inflammatory bowel disease, diabetes mellitus, celiac disease, multiple sclerosis, and also psoriasis, as I delivered today. From that, our team is just conduct a research to evaluate the dysbiosis of gut microbiota in psoriasis patient in Indonesian population. The population is Indonesian, age 18 to 70 years old. The case group is a mild moderate psoriasis patient, with the control group is healthy individual. We check the gut microbiota profile using next generation sequencing with Illumina MySeq machine. After we done the bioinformatics analysis, we have these findings that there were the significant gut microbiota profile difference between psoriasis patient and healthy control. The most notify the difference is in beta diversity. This is a healthy control group, and this is the psoriasis group. The beta diversity is different between two groups significantly. We can also observe the relative abundance diversity in subgenus, such as in Bacteroides, Faecalibacterium, and also Alloprophetella. The difference between two groups is significantly different. And also we observe the relative abundance difference on species level in Faecalibacterium prausnitzii, Succini vibrio dextrosolvens, Prevotella mansella dimonensis, and also Prevotella stercorea. And because of that knowledge, we thought about how if we regulate the gut dysbiosis using probiotic, is it able to also improve the psoriatic on the skin? From this picture, we know that the healthy gut means the gut microbiota biota composition is still in normal condition. So do the systemic and also skin environment. But when dysbiosis happen, where the composition of gut microbiota is not in homeostasis, it will influence the inflammation state in the systemic and also on the skin. But when we add some gut macrobiotic, where the probiotic will get the dysbiosis back into the normal composition of gut microbiota, we hope, or it assumed, that the inflammation on the systemic and also skin will recover too. And is it the assumption of the using of probiotic, the giving of probiotic can improve the psoriasis clinically using PASI score, psoriasis area and severity index, and also in pro-inflammatory cytokines. Now, until now, the efficacy of oral probiotic in psoriasis therapy is still under research in many settings. This is one of meta-analysis conducted by Zhang in 2021. There were 3 animal studies about this and 4 human studies. One of them is case control and 3 were clinical trials. From those studies, Zhang performed the pool analysis and showed that the probiotic improved PASI score better than placebo. But the quality of the evidence, our previous study is still limited. That's why we perform our study about the giving of probiotic Lactiplanti Bacillus plantarum ES10605. This is original strain from Indonesia in improving disease severity and also biomarker for psoriasis vulgaris. The population of this study is mild moderate psoriasis patient. The intervention group have a probiotic twice daily, while the placebo giving a skim milk in a similar form and also twice daily for 12 weeks. And then we observe the clinical outcome through PASI score, psoriasis area and severity index score, and cytokine like interleukin 17, TNF alpha, interleukin 10, and also FOXP3. And after the interim analysis, the clinical findings we can see here that in both groups, actually the clinical manifestation has been approved. There's improvement in the clinical manifestation in both groups because beside the intervention, both groups have the standard treatment of topical corticosteroid. But there were a significant better PASI score in probiotic group, right, in the week 6 and week 12. And also after longer evaluation after the stop of probiotic administration, in a probiotic group, the survival time is longer than in the placebo group. So in our study, probiotic can improve clinical severity and also may prevent the flare of psoriasis. From the inflammatory cytokine, we can see here that interleukin 17 is also decreased significantly in probiotic group, but not in placebo group. TNF alpha level is also decreased significantly in probiotic group, but not in placebo group. So this probiotic is beneficial in suppressing inflammation in psoriasis. How about the regulatory cytokine? In our research, the interleukin 10, we know that this is a Treg cytokine was increased significantly in probiotic group, but it decreased in placebo group. FOXP3, who represent Treg also, was increased in probiotic group and decreased in placebo group. So we assume that this probiotic is beneficial in increasing regulatory cytokine in psoriasis. So the conclusion is psoriasis is an autoimmune skin disease where gut microbiota dysbiosis have a role in its pathogenesis. Then probiotic, who is a good bacteria, proved to have ability to reconditioning gut microbiota dysbiosis. In our study findings, support the benefit of oral probiotic in regulating immune system and improving psoriasis severity. And probiotic has promising effects as adjuvant in psoriasis treatment.
Good morning, ladies and gentlemen. Now we can discuss about the topic, the medicinal properties of Borasius flabellifer L. We are from Faculty of Dentistry, Universitas Trisakti, Jakarta, Indonesia. Myself is Yanti Sudiono, and the co-author is Renita Rosalin Rosalinda Angeline. We have already known that medicinal plants with their bioactive compounds can provide better health for human beings. For example, the Borassus flabellifer, that is popular with the local name in Indonesia as siwalan or lontar, is the most popular type of the palm tree that has an important role in human health because it's believed it's more safe, more efficient, and also has the least side effects. Several studies that has been done revealed that the seed coat of this Borassus flabellifer L ethanol extract contains very strong natural antioxidant. For example, flavonoids, phenols, and tannins that can be function as antibacterial, antifungal, and anti-proliferative properties towards the pathological cells, including the cancer cells. We can see here the palm tree with their part. This is the fruit and the seed coat. The objective of this systematical review study is to give a comprehensive review of the medicinal properties of the Borassus flabellifer L plant. The method we use here as comprehensive review on the medicinal properties and the usage of Borassus flabellifer L, especially in dental and medical field, was done by collecting, reviewing, correlating, integrating, interpreting, and finally concluding the several studies done using this Borassus flabellifer L plant. As the result, the palm fruit contains natural antioxidants, especially from the group of xanthophylls and phenols that can be derived from various parts of this herbal tree with different strength intensity, whereas the seed coat part can outperform than their leaves or young pulp through the ethanol extract study. According to the study of myself and Susanto on 2021, the seed coat ethanol extract of Borassus flabellifer L contain several antioxidants such as flavonoid, phenol, tannins, as shown and on this table, which show the very strong antioxidant characteristic that is as much as 25 microgram per milliliter of ethanol extract for flavonoid and phenol, while for tannin as much as 5 microgram per milliliter ethanol extract. This antioxidant can neutralize the toxic effect of the free radicals. Also can fight the DNA damage due to exposure to the oxidative stress that can result in the malignancy transformation. According to the Tiatana and myself study on 2021, the seed coat ethanol extract of this Borassus flabellifer has cytotoxic effect towards the cancer cell, towards the normal cell, which is the fibroblast cells, that we use the cell line of this cell with the name HDF line, with the IC50 value that is categorized as mild toxic, started from the concentration very low, which is of 1.56%. The cytotoxicity effect increase following the increase of the concentration as shown on this bar diagram. About the cytotoxicity effect of this extract against human cells can be seen here the mechanism, flavonoids can be toxic to cells due to its ability to perform the cell rupture or lysis of cells, with use the excessive amounts of the extract. Alkaloids has cytotoxic effect, resulted in the leakage of the membrane cell. Tannins can cause cell mutation, especially at high concentration of extract, that can break down the fat lipid from the lipoprotein within the membrane cell. Result indeed in the disruption of the membrane cell permeability that leads to the necrosis of the cells. According to the study of Banu et al. At 2020, the extract powder of Borasius flabellifer proven have antibacterial effect, anti-cancer, cytotoxic effect, and also anti-diabetic activity. Antibacterial, especially with the maximum inhibition toward the pneumonia bacteria with the name of Klebsiella pneumoniae, and also towards the E. coli, while the minimum inhibition towards the Bacillus subtilis and Staphylococcus aureus. The anti-cancer effect through inhibiting the growth of several types of cancer cells, such as from the cervical cancer with the name of SELA cell lines, cervix uteri cancer. The cytotoxicity effect towards the monkey renal epithelial cells with the name Vero cell line with IC50 value categorized as highly toxic, which is of 734 microgram per milliliter. While the anti-diabetic activity through the inhibiting of the enzymes such as alpha amylase and alpha glucosidase enzyme that can delay the glucose absorption. According to the study of Celine, myself, and Trisvila on 2023, the seed coat extract of Borasius flabellifer fruit can reduce the ability of the tongue cancer cells that we use the cancer cell line with the name of HSC3 cell line. With the very high IC50 value that categorized as highly toxic, which is of 141.9 microgram per milliliter, starting from the high concentration that is of 93.75 microgram per milliliter, with the optimum concentration is of the 1,500 microgram per milliliter, as shown on this bar diagram table. The result in dentistry proven that several parts of Borasius flabellifer L, such as seed coat, root and sap, could inhibit the growth of the oral normal bacteria, such as S. mutans, S. aureus, and also the fungal Candida albicans. S. mutans is well known as cariogenic bacteria. This is achieved by the antibacterial properties through antioxidant activity. For example, tannins able to deactivate the adhesiveness of bacteria and also the mechanism of the enzyme of protein transport to the cell through the destruction of the basal cell, bacterial cells membrane, while flavonoids through several mechanisms such as inhibition of the nucleic acid synthesis, membrane cell function, and also energy metabolism. Terpenoids through the destruction of the bacterial cell membrane. All of these antibacterial properties, principally interact with the active membrane by dissolving the lipid component, leading to the increase of the membrane cell permeability, resulted in the membrane damage. The result in dentistry also proved that the fruit juice of this herbal tree able to eliminate the halitosis and also inflammation through the antimicrobial effects, including antifungal effect, such as of the Aspergillus flavus. The antioxidant properties here act, especially the polyphenol content within the seed coat of this herbal tree. Now we can conclude that the Borassus flabellifer L plant could be used for the medical health purposes due to its medicinal properties, such as strong natural antioxidant content, mild toxic nature, cytotoxic and anti-proliferative effect towards the cancer cells, antibacterial and antifungal properties. That's all our presentation. And finally, we will say thank you for your attention.
So good afternoon, everyone. Fellow doctors, professors, as well as SciTech's conference committee. Greetings from Malaysia. I'm Dr. Nicole from Malaysia. And just allow me to briefly introduce myself. Okay. So I'm a medical doctor for 10 years and 4 years experience in basically specializing in skin pigmentation as an aesthetic doctor. So it's my privilege and honor to represent our clinic, UR Clinic. Okay, so UR Clinic to share about our research in melasma. So allow me to briefly introduce UR Clinic. So UR Clinic is established in 2014, which is 10 years ago, by our CEO, Dr. Fong, with the mission of helping women to nurture their inner and outer beauty through modern science and holistic approach, as we believe that women play a very important role in society and family. And it's my privilege and honor to learn from all the wonderful women, the presenter ahead of me. Thank you so much for being so inspiring. And we believe that women's love can change the world. So currently, UR Clinic, we have 9 clinics across Malaysia, specializing in skin pigmentation. So without further ado, just let me share on our research on the safety and efficacy of combination of 10 session of Q-switch NDR1064 and pulse dye laser 595 nanometer on melasma treatment among Chinese women in Malaysia. Okay, so these findings has already been published in March 2024 in JAPA, which is a peer-reviewed and open access full online journal covering various aspects like medical science, in particular like aesthetic medicine, aesthetic surgery, as well as cosmetic dermatology. So feel free to visit JAPA. This is an overview of my presentation today, whereby I will discuss on the background methods as well as the result of our research work. So for the reason of selecting this topic as our core research is that because in Southeast Asia, the prevalence of melasma is as high as 40% in women. So as we know that Malaysia is a tropical country with sunshine all year round, and our multiracial population is at risk of developing melasma. I believe that many experts over here would agree with me that treatment of melasma can be tough at times. So why is it so? From the picture illustration here, it actually shows the various photomechanical or pathology of a melasma. So in 2021, Z et al. Actually reviewed 766 relevant articles, and they come up with 5 main photomechanical of a melasma. First and foremost is, of course, the inappropriate activation of melanocyte, as we know. Second is the aggregation or the clumping of the melanin in dermal and epidermal layer. And most of all, because it's an inflammatory process, there's upregulation of mast cell, causing alteration of basement membrane, solar elastosis, as well as there is a lot of damaging in the dermal layer. And most importantly, one of the photomechanical causes is there is an increase in vasculature. Actually, they suggested that the increased vasculature observed in melasma was due to the elevation of VEGF, which is an angiogenic expression. VEGF is known as the vascular endothelium growth factor. You can see over the right photo illustration over here. Okay, so after understanding the background of melasma, we would believe that actually many experts will agree with me that treatment of melasma can be tough at times. So why is it so? It's because sometimes the treatment can ranges from just a topical to oral medication up to a laser treatment, from a monotherapy to a combination therapy. But all of the treatment actually carries just one aim, that is to maximize the result and minimize the complications such as post-inflammatory hyperpigmentation. So based on the photomechanical things that I've mentioned previously, in our research, we actually use a combination of laser therapy, which is the Q-switch and the 1064, which deliver at extremely high peak energy in short time, which is nanosecond, resulting in destruction of melanin by photoacoustic effect. So you can see over the right illustration over here. Okay, so this result in targeting the intracellular melanosome, leading in less inflammation, and consequently, it will result in lesser post-inflammatory dyschromia. So besides from that, when you combine it with pulse dye laser, 595 nanometer, actually pulse dye laser is targeting on the vessels that I've mentioned. It's also one of the photomechanical effect in the melasma. So when you combine both of these, the treatment outcomes will be better. Okay, so why do we select combination of Q-switch, Nd:YAG, and pulse dye laser as our primary treatment? Is because it is safe, effective, with no downtime, and best suited for the modern era women. So sorry. So sorry for the hiccups. Sorry, let me continue my sharing. So moving on to the methods. So for this study, we actually do a retrospective study whereby 27 patients from our clinic across Malaysia associated with melasma was recruited, and they were treated by 10 sessions of combination of this treatment with the interval of 3 to 4 weeks apart. Then the study period is from January 2022 to December 2022. So how do we assess this patient melasma? Is by photography. So we will take a 5-angle photo whereby we will take the front view, the right and the left 45 and 90 degree. This is a comprehensive view to view all the areas of the face, not to miss out any, and it will be assessed by a third-party doctor, a credentialed doctor, based on the modified Massey score. So modified Massey score is an international score used to score the intensity as well as the surface area of a melasma. So how do we score it? We will score by the 1st, 5th, and the 10th session of treatment. So this is the laser settings that we use for combination of treatment. We'll start off with Q-switch and the 1064, where the followings are the settings. We'll keep at a low fluence of 0.5 to 1 joule per cm square, spot size of 8, and frequency of 10. So Q-switch and the we will go around 2,000 to 4,000 passes per patient per phase. And pulse dye laser 595 subsequently followed by the Q-switch and the is at a fluence of 0.15 to 0.3 joule per cm square, spot size 5, and frequency 2. So we'll go around 300 shots. Okay. So of course, during the procedure, we also observe for the endpoint. Okay. This is the demographic of our data, whereby 100% of them, they are mostly women with the peak age at 40 to 45 years old. And most of them, they are Chinese with fixed spectric 3 to 4. So when evaluating the adverse reaction during each visit, it was found that majority of the patient, they did not experience any adverse reaction. while a minority experienced redness as well as hyperpigmentation from the combination treatment. So for the patient experiencing redness, actually 1% of hydrocort topical was administered, and the patient was advised to rest for 1 month before reassessment. Following this intervention, the redness actually completely resolved. So regarding those patients who develop hyperpigmentation, majority of them actually encountered during the 5th to 8th session, coinciding with their perimenopausal age, which range from 45 to 55 years old. So the managing strategy for this individual, including counseling of adherence to broad spectrum sunscreen, extending the treatment interval from 3 to 4 weeks to 5 to 6 weeks. As a result, patient observed a reduction in hyperpigmentation. Okay, so allow me to share with you all the result of our findings. So there is two forms of result presentation. One is in a graph form, one is in a table form. So as mentioned, we assess from the 1st, 5th, and 10th visit using the mean MASI score. So you can observe over here, the first visit, the mean MASI score is from 8.74, and comparatively, it drops to 6.33, which p-value less than 0.05, which is significant. However, from 5th to 10th session, the reduction is slightly lesser, from 6.33 to 5.99. Okay, so the reduction is greater from 1st to 5th, but lesser from 5th to 10th. Okay, this is a photo illustration of a lady, a Chinese lady with Fitzpatrick 3 to 4, showing her right lateral view. You can clearly see that there's a melasma expressing on the right cheek and over the forehead, as well as the perioral region. So from the first visit, this lady shows a reduction in mean MASI score, whereby the intensity and the surface area of the right patch melasma is actually reducing, and further reduction in intensity as well as the surface area from the 5th to 10th session. Okay. So like what we know, most of the time melasma, they express bilaterally. When you have it on the right, you will definitely have it on the left. So you can see there's also expression of melasma on the cheek area, but the left side is actually slightly lesser in terms of its surface area, but the intensity is almost the same. So you can see from the 1st to 5th visit, after combination of both Q-switch NDR and pulse dye laser, actually the redness and the flushes also did show improvement as well, and further reduction from 5th to 10th session. Okay. So in our clinic settings, we actually have this AI machine to assess the intensity of the blood vessels pooling on the skin. So you can see from the 1st to 10th visit, with combination, especially the pulse dye 595, the redness actually shows a significant improvement, especially on the mala area, which is the melasma distributive area. Okay, so what can we conclude from our discussion? First of all, the treatment option. So using combination treatment, it's safe and effective, whereby the low fluence Q-switch NDR is safe because it's targeted on the melanin. Pulse dye laser, it's good, it's because it's targeting on the neovascularization, which is also one of the photomechanical contribution of the melasma. And both of them, they are safe and effective with minimizing the adverse reaction like PIH or what we call as post-inflammatory hyperpigmentation. And there is notable improvement whereby you can see from the photos and from the scoring, there is a significant improvement, especially over the 1st to 5th session. Why is it so? It's because we believe that it's attributed by the subcellular selective photothermolysis, whereby it's targeted on the melanin or the melanosome and the melanocytes, as well as the neovascularization. So the challenges here that we face is that we notice that there's a decreased improvement from 5th to 10th session. Why is it so? It's because it might likely be due to the heterogeneous nature, whereby I've mentioned earlier on, like the alteration of basement membrane, solar elastosis, which is not addressed here. And the last discussion is that using combination treatment, one is targeting on reduction of melanin, another is targeting on the reduction of neovascularization. This treatment approach actually shows potentials to prevent melasma relapse post-treatment. So for my conclusion is that combination of 10 sessions of Q-switch NDR 1064 and pulse dye laser 595 nanometer has proven to be effective and safe in treating melasma in individuals with Fitzpatrick skin type 3 to type 4, particularly in the fifth session. Although improvement diminished from 5th to 10th session, the treatment remains to be safe. So to optimize result, we suggest that additional treatment targeting on various aspects of melasma during or after 5th session laser treatments are proposed based on this finding. So further research is deemed and essential to enhance our understanding on and management of melasma. In fact, this year, our clinic, we are working on the extension of this research, exploring the safety and efficacy of combination of laser with other modalities such as HIFU as well as polynucleotide in identifying other heterogeneous cause of melasma. So please stay tuned. Okay, these are all my references. Thank you so much for listening.
Thank you so much. This is Dr. Shreyas here. Thank you so much for the organizers for bringing doctors and people around the world together to share knowledge and for the betterment of human health and society. So this is one kind of a topic which I selected, which is a kind of a review article which we had published, and I would like to thank also my co-author, Dr. Shruti G. Madhavi, and also my place of work, Banavi Hospital, and myself running Shreyu Skin and Hair Clinic in India. So this is sound alike conditions in dermatology. So why the sound alike conditions in dermatology? Now, the thing is that in sound alike conditions, why this topic? So because when I did my, residency in dermatology, I was kind of happy to get into this branch, but also at the same time, I was confused. How do I remember so many terminologies? And, we have seen this in conference itself. We have seen many doctors who have, told so much of those names which are volatile, which are difficult to pronounce, which are probably tongue twisters and all these things. So there are many terminologies apart from dermatology in many fields of medicine which look alike or sound alike or named after a person that we call as an eponym. So this is more of a theoretical topic, but for those doctors who are practicing clinical dermatology, it makes a lot of difference to diagnose and differentiate between disorders, which is quite cumbersome. So this actually is a list of about 78 conditions which look alike or which sound alike actually. So it's very difficult to cover all of them in this webinar, but I would focus on most commonest things and few of them which may be a little bit rare, with some relevant facts which help us to diagnose it. And also this also can help residents in dermatology who can quickly memorize the facts for their boards actually. So in the field of medicine, it is easy to find an abbreviation which exemplifies for a couple of different things and also similar words. So this similarities may be with names of disease, names of drugs, and many other things. So the names may appear alike when it is written for communication purpose or even sound the same when pronounced. So this difficulty occurs with names of medications, especially in emergency wards, with diseases, and furthermore, like I told, dermatology is a difficult vocabulary. So this condition may sound similar or be read similar and share words or roots of words. So this picture in this slide, we can see like we spell alkalosis, aniklosis, effusion, infusion, and there's a list of drugs like prednisone, prednisolone, calcipotriol, calcitriol, hexamidine, hexatidine, heparin, heparoid. So it does a lot of difference. You say prednisone and someone gives prednisolone. And the doctor says take ketotifen and it is heard as ketoprofen. So it makes a lot of difference. We can see look-alike, which is more dangerous to give a medicine which looks alike instead of a different one. So this becomes very important in a clinical practice in a day-to-day, especially in emergency where you run around and you might pick up a wrong medicine and give it to a patient. So similarly, here we are talking about dermatology with dermatological terms. So this is my own name, which many people throughout my residency got confused. So there is two different ways of writing it, but it is being spelled the same. So I have suffered or become a victim of this pronunciation or look alike or sound alike. I have missed my residency attendance many times because of this. So this is a little bit an interesting topic. So just look at the few things. Like we see actinomycetoma and actinomycosis. So actinomycetoma, as we see on the left side, is because of deep fungal infections. We see the bacterial infections like nocardia, streptomyces, and all these things. We can see those sinuses which are propping up and induration on the feet. Whereas actinomycosis is a different thing, which we call as a lumpy jaw caused by Actinomyces israeli. So both are different, totally different clinical presentations. One is actinomycetoma, one is actinomycosis, which can get easily confused. Similarly, we have actinic prurigo on one hand and actinic granuloma on another hand. So actinic prurigo is more of a polymorphous-like eruptions, which can appear on the sun-exposed areas. Whereas actinic granuloma is a type or a deep granulomatous inflammatory disorder, which may be a continuation of the granulomatous disorder. So both are different. We see one is a polycyclic lesions with a central clearing, and one on actinic prurigo are just raised papules with erythema. So those are both are different conditions, but they can look alike, and they can be confused very easily. So similarly, we have one more condition like atropoderma and anitoderma. So this anitoderma is like a pouching of a skin on a particular area where we see a buttonhole sign, whereas in atropoderma, it's more of a depressed cups. So both are totally different. So similarly, we have by the name of Bart's. So we have Bart's syndrome, we have Bart's-Pumphrey syndrome. So this Bart's syndrome is an autosomal dominant disorder. We see in the picture that it is a collagen 7 mutation where it can be associated with aplasia cutis congenita of lower extremities, plus a dominant dystrophic epidermolysis bullosa. So we have a Bart's-Pumphrey syndrome where it's an autosomal dominant disorder where there can be diffuse PPK with knuckle pads, leukonychia, and deafness. So we have one more term with Buschke. So there is a Buschke-Ollendorff syndrome, and there's a Buschke-Ollendorff sign. So this Buschke-Ollendorff syndrome is nothing but dermatofibrosis lenticularis disseminate, whereas the Buschke-Ollendorff sign is a deep dermal tenderness, which is elicited in secondary syphilis on pressing the lesion. Again, we are coming with one more term with Bazek's. So this can be really confusing. There is Bazek syndrome, which has a synonym called an acrokeratosis paraneoplastica, and there's a Bazek syndrome. To make it more confusing, there are synonyms like Bazek's Dupre-Pistol syndrome. So both of them are totally different. One is a psoriasiform-like disorder involving the hands and feet and nose and associated with aerodigestive malignancies. And one more are multiple occurrences with BCC, with hypotrichosis, with hypohidrosis, with follicular atropoderma, with milia, which is more of a X-linked disorder. And one more, which affects the lips, we have cheilitis glandularis, and we have cheilitis granulomatous. So both are different conditions. They may look same, they may sound same. So this happened once in my practice. I had a case of herpes zoster with Hutchinson sign as the findings. So in the discharge summary, we had one of the residents who had noted the Hutchinson sign on the nail examination instead of the face examination. So this totally changed the whole diagnosis and caused a confusion, not only for me, for all of them looking into this discharge summary. So this is one condition here. And then we have cocaine. So comes by cocaine-Torrent and cocaine syndrome. So this cocaine-Torrent we see in the picture, it's more of a dystrophic epidermolysis bullosa, mainly on the extremities, there resulting scarring, whereas the cocaine syndrome, it is because of a mutation. So there we have multiple presentations like deafness, CNS disorders, and salted retinal pigmentation, like atrophy. And so this I was talking about. We had a case of this, but in the discharge summary it was written this because of the sound alike, the nature of this terminology. Hutchinson named after the person. So Hutchinson sign, so that the pigmentation of the proximal nails, that is a subungual melanoma, which is quite severe, whereas we have the most commonest the herpes zoster affecting the ophthalmic branch of trigeminal nerve presenting a Hutchinson site. So here there can be some problems in diagnosis and sound-alike conditions. So we have ecthyma contagiosum, we have ecthyma gangriosusum. So contagiosum is more of a ORF virus, whereas gangliosum is more of a infection by a bacteria. We have a livedo. It may be livedo reticularis, it may be livedo racemosum. So both are totally different. The livedo reticularis is like a mottled, reticular, reddish-blue vascular pattern typically on the extremities, whereas the racemosa is an irregular branching pattern, broken circular segments that are fixed and do not vary with temperature. So they can be associated with some syndromes like the Sneddon syndrome and antiphospholipid syndrome. So we have halopy. This is one more condition. We have halopy Siemens, and we have again one more condition called halopy Siemens syndrome, which is really confusing. So halopy Siemens is an autosomal recessive disorder because of collagen 7 mutations. Whereas Siemens syndrome, we call it more for recessive dystrophic epidermolysis bullosa. So we have similarly a necrolytic disorders, necrolytic apical erythema, necrolytic migratory erythema. This happened that my friend who was on call, we were discussing the case, and she herself or he herself got confused with these conditions and suggested a differential diagnosis. So was asking whether the patient had a glucogonoma or some disorder, but it was supposed to be a apical erythema, which is associated with zinc and hepatitis C virus infections. So migratory erythema, where we look into glucagon secreting tumors of the pancreas and erythema, and this erythematous crusted, often found on the trunk, on the face, and the groin and the abdomen. So these are the differences which can be there in sound-alike conditions in the dermatology. So in conclusion, so dermatology is a branch of medicine with numerous lengthy terminologies with each disease condition. So this article or it can highlight the awareness of dermatologists and also related healthcare professionals of these confusing terminologies and sound-alike conditions in daily practice, as they can most often be confused and mistaken. Hence, this is just an attempt to bring all such terminologies under one roof, so for better and quick understanding and to prevent some unrelentless diagnostic error. Thank you so much.
Good afternoon, everyone. I'm Dr. Ratnakar Shukla, Director of Dermagenics Skin and Hair Clinic from India. And today I'm going to present my talk on capillaroscopic nail changes in collagen vascular disease. So what is capillaroscopy? Capillaroscopy is a non-invasive technique which allows one to visualize a microscopic visualization of the subsurface vascular structure, which is not normally visible to the naked eye. Capillaroscopic nail changes are most commonly associated with the collagen vascular diseases. And because of the translucency of the nail plate and proximity of its vasculature, the nail should be scrutinized routinely when examining the patient, especially in a patient with collagen vascular diseases. The aim of my study to compare the nail changes and study the various changes in the nail in cases of collagen vascular disease through capillaroscopy. Coming to the material and methods, we have included adult patients with clinical and immunological evidences of the collagen vascular diseases. Consent were taken. Patients were then explained about the procedure. We have clicked clinical photographs as well. Patient hands were first cleaned with the spirit and gauze. After that, a drop of oil is placed on the nail fold to enhance the skin transparency. Capillaroscopy of all fingernails was performed, especially the 4th and 5th fingernail, because they have the highest transparency. The obtained findings were then recorded and compared. We have used this VIOS SD2 dermoscope for doing the capillaroscopic examination of the nail plate. In our result, a total of 50 patients were included, out of which 43 patients were female and 7 were males, clearly indicating there is a female preponderance in collagen vascular diseases. Out of all the diseases, 17 were systemic sclerosis and 16 were systemic lupus erythematosus, which is a major chunk of the disease. 6 of them were DLE cases, which is discoid lymphocytodermatosis. 3 patients of mixed connective tissue disease. 5 patients of dermatomyositis. 2 patients of rheumatoid arthritis, and 1 patient is of Sjogren syndromes. Coming to the nail changes, transverse nail raising has been found in the 4 patients. Out of those 4 patients, 3 patients were of systemic sclerosis and 1 patient is of mixed connective tissue disease. Dilated capillary loops is again found in the 4 patients, and all 4 were cases of systemic sclerosis. Racked cuticles were seen in 3 patients, and those cases are of SLE. Periangual erythema is seen in the 2 patients, and out of those 2 patients, 1 patient is of SLE and 1 patient is of DLE. Fingertip scarring is present in 1 patient, which is a case of systemic sclerosis. As you can see in this diagram, a splinter hemorrhage is clearly seen in the black circle in a case of scleroderma patient. In this picture, you can see ramified capillaries, which is present in the active cases of the scleroderma. Slight disorganization of the capillary structure, clearly indicating by capillary dropout and a few joint capillaries, which suggest active scleroderma cases. In this picture, you can see racked cuticle and transverse nail raising, which is present in the SLE patient. In this picture, periangual erythema is clearly visible in case of SLE. Coming on to the discussion part, in 1973, Marek and Leroy first described the capillaroscopic pattern in systemic sclerosis. And in 2000, Cutolo et al. Described 3 major nail fold capillaroscopic pattern for systemic sclerosis, which is early, active, and the late. Abnormal nail fold changes are now listed as one of the classification criteria, even by Euler criteria. And it not only helps in diagnosing, but also helps in the determining disease activity as well. Nail fold capillaroscopy in Raynaud's phenomena. So it is one of the most important indication. It helps to differentiate between the primary and the secondary Raynaud's phenomena. The dermoscopic finding in patient with secondary Raynaud's phenomena or capillary hemorrhages, avascularization, and ramified capillaries, whereas pin-sept capillaries are seen in the primary Raynaud's. The common nail changes in collagen vascular disease include transverse nail raising, dilated capillary loops, periangual erythema, racked cuticle, and fingertip scarring. Coming on to the early pattern of changes in systemic sclerosis, there is preserved capillary architecture in early cases. Few giant capillaries can be seen and few microhemorrhages can be present, but there is no evidence of capillary loss. When the disease advances and comes into the active pattern, there is a more disorganization of the capillary architecture compared to the early pattern. Multiple giant capillaries and multiple microhemorrhages are present, and there is a moderate amount of capillary loss as well, along with few ramified capillaries. In the late pattern of systemic sclerosis, there is a severe derangement of the capillary architecture. Almost there is an absence of giant capillaries and microhemorrhages, and there is capillary loss with avascularization. Vascular changes, which is caused by functional and structural abnormalities of the microcirculation, play a central role in the pathogenesis of the collagen vascular disorder. Nail fold capillaroscopy is a simple, non-invasive, inexpensive, and useful tool for the study of the microvasculature. It can act as mirror for the microangiopathy and thus as a prognosis of these diseases. These new age dermoscope are compact, handy, pocket-sized instrument which allow us to capture images and store for future references as well. The limitation of my study is to inclusion of the large number of the patient, because we have a limited number of the patient. So if there is a larger amount of or larger pool of patient, it will further strengthen the observation of my study. There is a lack of follow-up. So repeated dermoscopy over a period of time in cases can act as a better method of evaluating the findings as a prognostic marker during the course of the disease. To conclude, I would like to say that capillaroscopic nail findings gives us not only an important clue in the diagnosis of collagen vascular disease, but also it can be used as a prognostic marker of collagen vascular disease over a period of time. These are my references, and with this, I would like to say thank you for your listening.
Good afternoon to all. The topic of my presentation, ma'am, am I audible, ma'am?
Yes, you're audible.
Yeah, thank you. The topic of my presentation is recent advances in invisible orthodontics. Everyone loves to have a beautiful smile, and to create a smile which is really attractive, and at the same time, we do not want others to know that we are doing something with our smile. So that is the meaning of invisible orthodontics. So there are different methods by which you can achieve a beautiful smile. You can use ceramic brackets. Now, ceramic brackets are aesthetic brackets. It has the color of the tooth, and so it looks very appealing to the viewers. And so this is, instead of your metal brackets, you can use ceramic brackets. Another option is to use lingual orthodontics. Now, in lingual orthodontics, you do what is done on the labial surface, the same mechanics we do it in the lingual aspect, and so that the visibility of the brackets will not be seen by anyone, but at the same time, the treatment
Dr.
will
sorry
take
to
place
interrupt you, but
properly.
we can't see your slides. We can only see your background.
Oh,
Can you please share your?
I think I've shared my screen. 1 minute. 1 minute, ma'am. Sorry. Sorry. Is it visible now?
Yes, we can see it now.
So sorry.
No, that's okay.
Can I start from my present slide?
Sure. Could you also put it in full screen?
Sure. Yeah. Is it okay, ma'am?
Yes, it's perfect. Thank you.
Really sorry. Okay, so I was just talking about invisible orthodontics. That is, you try to create a beautiful something with your smile makeover. So there are different methods by which you can do. You can use ceramic brackets. At the same time, you can use the tooth, leaving the labial surface of the tooth free. It looks very talking about he has done a smile makeover. He's used ceramic brackets. Unfortunately, the arch wire which he has used is black in color. And to add on to all this, he's used modules holding the arch wire onto the bracket, and that usually it gets stained within 1 month. So it actually is not very aesthetic. If you just come close to this person, you will know that he's doing something with his smile. And so instead of using black arch wires, we can use arch wires which are aesthetic, that will be Teflon coated. And usually, if the ceramic brackets, they are arch wire moves is very rough, which creates a lot of friction for the arch wire to move smoothly. So instead of using all ceramic brackets, we can use ceramic brackets with metal slot, which will enhance the free flow of the arch wire, which will increase the speed of the treatment. Another option and most cleanest method where you can use ceramic brackets is by the use of self-ligating brackets. Now, self-ligating brackets, they do not have the modules, and it is really very aesthetically appealing. It doesn't discolor, and till the treatment gets over, you will have a very nice, pleasing appearance. Now, talking about lingual orthodontics, that is the orthodontics that is done on the lingual surface of a tooth. Now, bonding in lingual orthodontics is very important because the lingual surface of your tooth is very irregular. It doesn't mimic each other. I mean, all the teeth are unique in their, more than the label aspect, the lingual aspect is very different. So there are different methods where we can do bonding. The first one is by Hero system. The second one is by using DA system. And the third one is by using the TAG machine, that is the top angulation and bracket positioning device. By all these methods, you can do indirect bonding onto your tooth. Now, before doing lingual orthodontics, we should know which patients are eligible to do lingual orthodontics. And basically, the biomechanics also, when you see that the distance of point of application from your labial surface to the lingual surface, you can always see that the distance from the point of force application to the center of resistance of your tooth is more shorter in a lingual appliance compared to a labial appliance. And once the distance is less, the amount of force that is exhibited, that is with a very little bit amount of force, you can exhibit a lot of work that can be done. Even when we see on the occlusal aspect, if you want to generate a moment, the amount of force, nearly just 1/3 of what is required by a labial appliance is just required in a lingual appliance. So that is the maximum effect that we can produce using a lingual appliance. And there are a lot of appliance advantages. Like you have a bite pad, and subsequently you will be biting onto this bite pad, which will help in bite opening mechanism. And when we see all the arch expansion appliance like the pendulum appliance, it has its arena of action on the palatal aspect of our mouth. So keeping this lingual appliance, it has a lot of advantage in maxillary arch expansion, molar distalization, and the brackets on the lingual aspect hurts the tongue. And as it is, it acts as a break or a habit breaking appliance for tongue thrusting habit. Now, when we see the disadvantages of lingual orthodontics, it is really very tedious for the operator as well as for the patient. The patient has to bear with all the brackets and the tongue keeping on touching onto the bracket, and it causes soreness of the tongue. And the amount of time that we spend for the patient is increased. Maybe around 3 patients, we would have seen the time taken for 3 patients that we treat with labial appliance, we need for doing a lingual appliance. So the chairside time is increased, and even the precision should be perfect, because a little bit of force excess is given, then you will end up in a tooth movement, which will be, you will have to do much more to correct the unwanted tooth movement. So that is you should be more perfect in what you are doing in lingual orthodontics. And when we come to the difficult lingual cases, do not do lingual orthodontics for patients with high angle dolichocephalic facial pattern surgical cases, and those with multiple tooth which is restored, because as it is, the tooth will not be very strong, and bonding it on the lingual aspect will also reduce the strength of the tooth. So do not go for lingual cases in such situation. And cases which are really contraindicated are especially patients who are not cooperative. They are not a patient for lingual orthodontics. Those who cannot keep their oral cavity clean do not do lingual orthodontics, because cleaning the labial surface itself is, if it's not possible, then they will never clean the lingual aspect of it. And those with clinically short crowns and those who have temporomandibular joint dysfunction do not do lingual orthodontics. You will just be worsening their situation. And coming to the treatment mechanics, as usual, it's like initial leveling. And another step is like you have to establish a talk. Talk establishment is very important in lingual orthodontics, because when we start pulling the brackets for retraction, eventually what happens is your tooth will start losing talk and your tooth will start becoming retroclined. So before we do the retraction, it's always good that you do the establish their talk and then do the end mass retraction, and finally we go ahead with the finishing and detailing. So today I'm planning to do 3 case presentation. 3 I have done in different methods of bonding system. The first one is the hero system of bonding. Nearly 1 day is necessary to do the lab work when we are doing a hero system of bonding. So it's very tedious, but you can also do it by yourself. You don't need a lab to support you to do this type of a bonding. So this is my patient. She was a orthognathic maxilla and mandible, and she has a class 1 skeletal pattern with competent lips. And the only problem with her was that she was having mild spacing in the upper and lower anteriors. So we decided to do a treatment plan where we wanted to do lingual orthodontics for her because she was very conscious, aesthetically conscious, and she definitely was for doing lingual orthodontics. So we thought we'll do bonding with hero system, and we completed the case. I'll show you the method how we did it. First, we did the bonding for the lower because we wanted the lower to get retracted before we could do the bonding for the upper. So this is how your bracket jig will appear. And once your jigs are all removed with the air rotor, then you will have your brackets all in position. All this is the brackets which are bonded indirectly. And after that, we'll be moving on to the arch wires. We'll be upgrading the arch wires. And even if you see the arch wires in lingual orthodontics, there is an inset bend in your premolar region because your labial aspect, your anterior region remains like a mushroom arch wire, and there is an inset bend because of the distance from the distance on the lingual aspect from the canine. It's not as big as the premolar. So you will have to give an inset bend for all these situations. So wire fabrication and lingual orthodontics is also a task for it's a real job for the doctor who's handling a lingual orthodontic patient. And after this, we started closing the anterior spaces. And before the anterior spaces, after all that is controlled, then we did the torque control. We used a TMA arch wire. We established the torque before we could do the en-masse anterior retraction. Now here you can see the case is completed. All her anterior space is completed, closed, and you can see that she's smiling much more happily. So this is after the space closure, and now we've debonded the case, and this is the post-treatment appearance. You can see her extraoral photos. This is a comparison of your pre and your post-treatment photos. And definitely her smile has improved. And this is the intraoral photographs. And now next is a second case presentation. Here the method of bonding was using a method with DAS system of bonding. It's a lingual jig where you can transfer the torque which is present on your labial surface of your bracket. That same torque is transferred onto your lingual jig. I had mentioned in the earlier method of bonding, I took nearly 1 day to do a bonding for the patient. Whereas for this type of a method, maybe half a day is required to do the bonding for this patient. So this is the patient where he had, as seen in the photographs, he's an orthognathic maxilla, has orthognathic mandibles, class 1 skeletal pattern with lot of space in the anteriors, upper and lower anteriors. And so we thought we'll do just mild space closure with lingual appliance. And here you can see we did the anterior space closure, and the treatment is complete. We did lingual orthodontics, and this is the post-treatment photographs. And the third method of bonding is by using your TAG method. This is the article which I had published in 2017. And by God's grace, I had got the Luso Ann Award for this article, which was published. And this is the patient. She is a class 1 Bimax proclination patient. She has incompetent lips. And we just asked her whether she's willing to do lingual orthodontics. And she was very much happy to do it because she didn't want others to know how she's changing her smile. So usually if this patient comes to us to clinic, and if we want to do a labial orthodontics for her, we will prefer to extract the first premolar. But because we are doing a lingual orthodontics, we went and we extracted the second premolars for this patient. And this is the treatment plan after extraction of the second bicuspids. This is the way how they present it from the lab. The prescription, this is the amount of tip and talk that is included in the lab. And that is what will be expressed at the end of the treatment. These are the indirect bonding trays. You can see that this this is a jig because the canine bracket cannot be placed at the initial site because the tooth is crowded. So we'll have to wait for all the other tooth to get aligned, create space for canine, and then only we can do the bonding for the canine tooth. So this is how we did the bonding. And see, this canine tooth, this doesn't have space. So that was the jig that you had seen separately. So we will be doing the bonding for this after creating adequate space between these two teeth. And we use the wires. We had to bend all these wires depending upon the alignment of the tooth. We had to manually bend all these wires. And then you can see we did the upper bonding. And almost after the alignment is over, we placed the torque expressing arch wire with horizontal as well as the vertical bowing bends. This is very important because when we do retraction without these bowing bends, it will lead us into great problem if we are doing a lingual orthodontics. So this is where we place the 1725 TMA with the anti-bowing bends. And after the talk expression, we did the retraction, and this is how we completed the patient case. You see that the 5 where we had extracted, the space is completely closed. The midlines are coincident. At the same time, we have established a class 1 molar relationship. And this is a comparison of a pre and a post treatment. And recently, what we have seen in lingual orthodontics is the customized brackets, which is more comfortable for the patient, and the bonding is much more better. And this is all done computerized. It's all by CAD/CAM procedure that you do all this fabrication of all these brackets. Now, let's go to the most latest way of moving your tooth to the desired position is by the use of clear aligners. Now, there is basically a digital flow where we follow certain steps when we do a clear aligner. Initially, we have to take the model of the patient. It could be directly, you can take an impression and then scan the model, or it could be intraoral scanning itself. With that, we convert the original model into a virtual model, and then we import that model into the computer. And once you have fed the input to the computer, we start to do tooth separation. And once the tooth is separated, we will start doing the digital setup, and we'll do the staging and then the model printing. And once the models are printed, then we will start forming the aligner trays. So this is the workflow what we have to follow when we do a clear aligner therapy. So there are a wide variant choice that we can select in the market. The most common one is the PET-G. This is what these trays are what we most commonly use in in-office aligners. And the polypropylene material, this is used for attachment placement. And you have some aligner material like the multi-layer material. Now see, when you use an aligner, we want the surface of the aligner contacting the tooth to be more flexible, whereas the surface of the aligner, which is not contacting the tooth and it receives the bite, that should be more firm. So that is the reason why we have multi-layer aligner sheets. Okay. So there are several steps in planning your aligner. First is you have to set a treatment goal. What is needed in a patient? Does she need space closure, or does she need to unravel the crowded teeth? So in such cases, what are the method of gaining your space? Are you going to do proximal, interproximal stripping, or are you going to extract, or are you going to do distalization? There are different methods of gaining spaces. So which type of method? Before we could start the treatment in the computer, we should all plan how you're going to execute it before we start the treatment in the computer. Then whether we'll have to do treatment in stages or phases, maybe in certain cases when we want to do extraction case, we'll have to first do individual canine retraction, move the canines and keep it into a unit, and then we'll have to do the en masse anterior tooth retraction. Then we'll have to see for a synergistic and antagonistic movements of the tooth, and whether we need to place attachments for retention, or whether it is needed for biomechanical support. And then you'll have to decide upon the number of trays and the treatment time, whether overcorrection is needed. All this is what we plan before we could do in the software. Now, the question is aligner effective? Well, in 2009, the articles used to say like 41% of the desired tooth movement occurs. And in 2020, it became to 50% of what is required, the tooth movement occurs with aligner. But now the recent aligners, the articles say that nearly 90% of what is required and what is predicted by the software occurs when we do the aligner treatment. And there are several factors which influence the efficiency of your aligner. It is the material, the manufacturing method. If your material is not firm enough to give the desired force, the tooth movement will not take place. And depends upon the morphology of the tooth, depends upon the orthodontist, the patient, how he cooperates, whether he wears the appliance regularly. All this is important when we do clear aligner therapy. And talking about the time-dependent change in the material, creep, and the stress relaxation, all this is very important. Because if your material is not able to withstand the forces and it's not able to give the adequate force to the tooth movement, then tooth movement will not take place. Depending upon the trim line, whether you want the tooth to be highly, the aligner to be very retentive or just less retentive. Packing, if the patient is regularly wearing it every 15 days, and I had a patient who used to wear, never wait for 15 days. He used to wear it every 2 days, and he finally ended up breaking his aligners. So the patient should be really very cooperative and should follow the instructions which we give to the patient initially. There are several indications. Since the aligners have a push method of moving the tooth movement, any movements that causes intrusion, tipping, or docking is very compatible with aligners. And certain movements, like if you want to correct a scissor bite, single tooth cross bite, extrusion mechanisms, when you want to do impacted canines, it's very difficult to do with aligners, and it is only possible only if you use attachments with your and now the take-home message is that software
Good afternoon, everyone. Well, it's afternoon here in India. I don't know about what's the time there, but I hope you like my presentation. I'll try to keep it as short as I can. So I'm going to be talking about the role of non-fractional 1540 nanometer erbium glass laser in acne scars. So just a word about how acne or why acne happens. So it's basically a pathology of pilosebaceous unit, which are the oil secreting glands in the skin. Now, acne tends to happen because of either increased sebum production, because of which there could be follicular opening obstruction, and eventually because of increased sebum production, which leads to obstruction of the follicles. It can lead to growth of propionibacterium acnes, which result in very painful papular lesions or red raised lesions. Sometimes it can be associated with pus, and we call it pustules. Now, what happens to these acnes? Most of them resolve uneventfully without any scars. However, a lot of acnes resolve or heal with scars. So the most common scars that I see in my practice are macular scars. That is, it's a flat scar, but it has maybe a reddish hue to it, or it might be pigmented. Especially on an Indian skin, wherein, you know, in India, we see patients with skin type, Fitzpatrick skin type, Fitzpatrick skin type 3 to somewhat say 4 or 5. So if it is towards the fairer side, that is skin type 2 or 3, you see red colored macular scars. Whereas if it's skin type, let's say 4, 5, then you get hyperpigmented macular scars. The other common scars that we see are ice pick scars, which are scars that are so on the top, it looks like probably an open pore, but it goes very deep inside into the dermis. Followed by that, we see boxcar scars, which are a little flattened and U-shaped. Lastly, it's rolled out scars, which are M-shaped, and they are usually tethered to the skin. That's why subcision works really well in rolled out scars. Lastly, very rarely we happen to see hypertrophic scars or keloids. So now, this is just a grading which we follow. There are various other grades as well, but I like to follow this grade because it's a little easy also. So we grade the scars based on their appearance. So grade 1 is for just macular scars, which are not depressed, but are just discolored. Grade 2 is where there is mild atrophy or hypertrophy, like, you know, scars that are not visible from, let's say, social distance of 50 centimeter, and they can be easily covered up by makeup. Moderate scars are scars that are visible at a distance of 50 centimeters or cannot be covered by makeup. However, when we stretch those scars, they can be flattened. And lastly, we grade a scar severe if it is visible at a distance of 50 centimeter, cannot be easily covered by makeup, and cannot be flattened if we do a manual stretching of the skin. Now, just a word about lasers, how lasers actually work. So lasers cause photothermolysis of collagen, which is the chromophore in these kind of lasers which work on acne scars. Now we have ablative lasers and non-ablative lasers. So ablative lasers are like CO2 lasers, erbium YAG lasers. So ablative lasers form 3 distinct zones when we give a shot on the skin. So the first zone is the ablative zone. Followed by that, there is irreversible thermal damage which surrounds the ablative zone. And lastly, there is a zone of reversal tissue damage which surrounds the second zone, which is the irreversible thermal damage zones. Now, non-ablative lasers, they do not cause damage to the epidermis, and they have a higher affinity for water, thus it leads to less collateral damage. Non-ablative mode of lasers, like I said, they don't damage the stratum corneum or the uppermost layer of the skin. So that's the difference between the ablative and non-ablative lasers. Now, non-ablative lasers are either fractional or non-fractional. So the fractional lasers bring about these multiple microthermal zones on the skin when we fire a shot on the skin. Resurfacing in non-ablative lasers usually take about 24 hours, maximum 48 hours. So of course, non-ablative lasers have less downtime and are actually preferred on Indian skin because there's a less risk of post-inflammatory hyperpigmentation. Now coming to the laser that I want to talk about, which I work with in my clinic, that is the 1540 nanometer erbium glass laser. Now this laser penetrates till about mid-dermis, and it causes, so it's a non-fractional laser. So it causes bulk dermal heating, which results in uniform neocollagenesis or formation of new collagen, which helps in remodeling the acne scars. Now, this has a cooling tip, which helps in reducing the epidermal burning, because this is something that we really fear in Indian skin. And we really want to avoid that, because you don't want to have a patient coming in whom I'm treating for acne scars to come and tell me, doctor, I've gotten post-inflammatory hyperpigmentation. So we really want to avoid that complication, and a cooling tip really helps in that. Moreover, these kind of lasers, they have a vacuum in their tip, which increases the selectivity of chromophore, because the vacuum helps in kind of, because of the pressure, it kind of presses the skin against the tip. Hence, it increases the selectivity of collagen and helps in increasing the selectivity of my laser. Now, I just want to discuss few of my patients and show the results of the laser that I'm using in my clinic. So this gentleman walked in, had mild to moderate scars, mostly box scars. And this is his first session right profile, which, there was a slight improvement. He was very happy after the first session itself. And this is the left profile of the patient. So the right profile of the patient after 4 sessions. So clearly there was about a 50% difference and he was really happy. However, on the left side, again, this is after the first session of erbium glass laser. This is after 4 months because we spaced his sessions a month apart. So you can see that there is this PIH that has developed here on his left cheek. So this happened after his 3rd session. So in the first session, the energy that I gave him was 400 and 800 millijoules, 2 passes of each. And we gradually increased his energy to about 700 and 1200, 2 passes each in the 4th session. Now, the patient was very happy. There was about 50-60% improvement. From moderate to it went towards mild acne scars. Everything was very good. However, the only thing that he is worried with, and of course, he's eating my brain as well, and I'm also worried with, is post-inflammatory hyperpigmentation, which happened on his left cheek scar. So we're treating that at the current moment. Now, this is a lady who I really want to share this case because we had done Morpheus for her, which is microneedling with radio frequency for her. She had taken 2 sessions of that. However, she observed no difference with microneedling, which was with inbuilt radio frequency. So we started her on erbium glass laser. And this was after 2 sessions of her laser treatment. Although initially she said that, I don't see much of an improvement. And she mostly had box scars, very few ice pick scars. But she was very happy with the results. And, she tells me, doctor, now I do see an improvement. So because of this case, I actually realized that even a modality like Morpheus, which is a microneedling with radio frequency and is being used very commonly and is being promoted a lot for acne scars, somehow it did not work well. And in my experience also, I'm seeing that lasers somehow are giving better results as compared to microneedling in acne scars. So in her case, we started with a little higher energies of 500 and 900 in the first session. 2 passes of each, increased it to 700 and 1200, 2 passes of each in the second session. The patient was very much satisfied, and it was a learning curve for me as well that actually lasers work much better than microneedling when it comes to certain acne scars. This is another case. This is her front profile. Again, she had mainly box scars, a few rolling scars for which I did subcision. And this is her after 3 sessions. And this is, again, after 3 sessions of erbium glass laser. And we started with 400 and 800 millijoules, 2 passes each in the first session, increased it to 600 and 1100. The patient was happy, there were good results. And also we saw a reduction in the redness over scars, like I was talking about the macular scars. So it really helped with that also. And it also helped in her active acne. This is a patient yet again. If you can see, there's also around, there are these macular scars as well, which got a little better after the erbium glass laser treatment. So something that I would want to really talk about here in this case is that erbium glass laser really helps in reduction of redness on these macular scars, which worry a lot of people, at least a lot of patients that I see in my practice. This is again yet another girl who had box scars and rolling scars, a little bit of ice pick scars as well. And that's her after 4 sessions of erbium glass laser, right and left profile. Of course, there was improvement in the appearance of scars. We started with similar energies. Luckily, there was no post-inflammatory hyperpigmentation in her, and she was happy with the results. This gentleman, of course, I had advised him about 4 to 5 sessions, but this is his before and after 3 sessions of erbium glass laser. So you can see, especially he was worried about his scars on the lateral side of his forehead near the eye area. So there was clearly an improvement in these acne scars and also reduction in the redness around these scars. And this is on the left side. Of course, this left side was a better side. And we started with similar energies of 400 and 700 millijoules as fluence in the first session, increased it to 600 and 1100 in the third session. There was an improvement in his scar appearance, as in, when we talk about from being moderate to severe, it came down to mild to moderate. And of course, the reduction on the redness over scar was something that really, really helped him out. So now just wrapping all my observation and my presentation. So the good thing, there are many lasers out there which are being marketed for acne scars. So the reason I chose this topic was that I really wanted to put this point across to people, especially who all, who are into aesthetic practice and who all are dermatologists here or doing their residency in dermatology or whatever, in whatever phase of life they are in about their career. So, lasers are actually an edge over microneedling, if you ask me, when it comes to acne scars. That's something that I would really want to put my point forward there. I mean, for the longest time, I thought that microneedling works really well for open pores and acne scars, but having tried this laser, erbium glass laser, or other lasers also which are there, like erbium YAG laser, I personally feel that lasers work better on acne scars as compared to the microneedling, even if it is with radio frequency. The good thing about erbium glass laser is that you don't need to apply topical anesthesia because it has a cooling tip. It also has that inbuilt vacuum in it, so that you save on time, because usually if you have to do a CO2 laser or an erbium YAG laser, you have to put an anesthesia for about 40-45 minutes, which is again time consuming for both the patient and the physician. Secondly, the good thing about this laser is that, of course, I did get a patient who ended up with a PIH, but usually it is good for people who have a skin type of 3 or 4, and it does not give post-inflammatory hyperpigmentation or erythema. I saw visible improvement in 3 to 4 sessions. It helped in reducing redness over macular scar. And of course, there was reduced downtime. So when I tell my patients, I counsel them, of course, there'll be a downtime of, let's say, 4 days, 5 days. I tell them, please avoid any social gathering for a week. And the good thing about this laser is that it worked well on active acne as well. And my patients were very comfortable during the treatment and post-treatment also. But like I said, yes, one patient of mine ended up with PIH. So now I'm very careful, and in almost all of my patients, because I deal with Indian skin, right? So I try to give them a topical cream, even though the one who ended up with PIH had a skin type of 3, I would say between 3 to 4. He was not somebody who had a darker complexion or had high melanin content. But now it's a learning curve for me, that I have learned that in almost all of my patients, I tell them from day 5 of post the laser treatment, I give them a cream for hyperpigmentation, just to be on the safer side, that I don't land up again with PIH as a side effect of my laser treatment for acne scars. So that's all that I want to share with all of you. I hope I was not too boring and it did help you a little bit. Thank you everybody for your patient listening.
Good afternoon, everyone. So let me just begin with my topic, that is gingival depigmentation by scraping method by scalpel. Ma'am, slide.
Doctor, we can't hear you.
So, yes, ma'am?
No, it's fine, it's fine.
Okay. So let's begin with the introduction. So talking about the human being, I must say human being is a wonderful creature who has a mixed sense of emotions. And these emotions are basically in the form of anger, fear, smile, sorrow, joy, and so on. Coming on to one of the emotion, that is joy. So when a human being is genuinely happy, he or she expresses his or her joy in the form of the smile, a smile or a genuine happiness. Or we can say a smile is a thing that sets everything straight. And this smile, talking in that terminology, is a reflection of a balance between the position of the teeth and the color of the gums, that is gingiva in the field of periodontology, as it is said, and the competent lips. And any unbalance between these three modalities leads to a disturbance to disturbance for the human being to generally express his or her happiness. Ma'am, next slide. Yeah. So coming on to the topic, that is, what do you mean by pigmented gingiva? As we all know that we individuals have a skin color. Skin color, and this skin color is basically because of the pigment called as melanin. But yeah, other pigments are also responsible somehow: carotene, reduced hemoglobin, and oxyhemoglobin. So in the field of periodontology, that is the branch which deals with the structure around the teeth, that is the gingiva, and the supporting tissues, that is periodontal ligament, cementum, and alveolar bone. So coming on to the normal color of the gingiva. The normal color of the gingiva, according to the British population, is coral pink, and since I reside in India, it's pale pink. Now, this color is mainly because of the melanin. A melanin that is similar to the pigment that is the same melanin is secreted on the gingiva. Those individuals, ma'am, can you please help me out in changing the slides? Yeah. So those individuals, we can say, who have dusky skin color. In that case, the melanin is secreted in excess. And this excess melanin results in the blackish to brownish color of the gingiva, in which in our terms we called is the hyperpigmented gingiva or the hyperpigmented gums. And if these gingiva or gums are displayed, these hyperpigmented gums, if displayed during the smile, it it can lead to an aesthetic concern for the patient, because that aesthetic concern can somehow drop the individual confidence to express his or her joy. Now coming on to the topic, that is gingival depigmentation. Okay. So now in the field of dental medicine, that is particularly in the field of periodontology. Periodontology is a field which can deal both with the clinical modality of the tissue, gingival tissue, as well as the aesthetic modality of the gingival tissue. Now, as I told, this visible gingival pigmentation or hyperpigmentation is a major aesthetic concern of the patient. Hence, in the field of periodontology, a procedure is available, which is the cosmetic modality basically. This procedure is known as gingival depigmentation, which can reduce or eliminate this hyperpigmented gingiva and can revert back the normal color of the gingiva to the pale pink. Yes. Okay. So, talking about the gingival depigmentation, as I told you, it's a cosmetic modality. So what we do basically in the gingival depigmentation procedure, as we all know that melanin is a pigment that is secreted by melanocytes, and melanocyte is something that gingival depigmentation is to remove this melanin pigmentation from the epithelial tissue as well as some part of connective tissue. Now, for this thing, various treatment modalities are available. Like, you can say scalpel, in which I will be presenting it today. Other thermal modalities, such as laser, cryosurgery, electrosurgery, and gingival depigmentation by burr is available. But here I am going to discuss a very interesting case of gingival depigmentation. Now, my case presentation. Ma'am, case presentation slide. Now, when I was in my when I was pursuing my post-graduation from People's College of Dental Science and Research Center, India, and when I was in my final year as a postgraduate student, one lady came to the OPD department, a 21 years old girl, with the chief complaint of that she has a blackish, brownish pigmentation of the gums. And because of that, she told me, very personal issue, that because of that, her wedding was getting delayed and she wants the immediate treatment so that she can continue further to her wedding. That is also a feeling of enjoyment. And then we examine the patient both extraorally and intraorally. Now, upon the extraoral examination, now upon the extraoral examination, what happened was the patient was symmetrically oriented. There were no sort of, the medical history was non-contributory. The TMJ was normal on palpation. No clicking sounds was available for the TMJ. There were no palpable lymph nodes. And we went for the complete blood picture, because what happened is sometimes this hyperpigmented color of the gingiva can be because of some systemic disease. So, like the Addison's disease. So in that case, in order to rule out the medical history, hyperpigmented color of the gingiva for this girl is because of the oral pathology. Now, coming on to the intraoral examination. Coming on to the intraoral examination, yes. So, as you can see in the picture, there's a hyperpigmented gingiva, or you can say a brownish, more often a dark brownish color gingiva or the gums. That was visible both from the first bicuspid to first bicuspid symmetrically on both the sides. Now, procedure. So, as my today's topic is of the scalpel, so since the patient was in a hurry for the immediate results, so we decided to remove this hyperpigmented gingiva by means of the scalpel, in which we use the Bart-Parker number 3 blade, Bart-Parker number 3 handle along with the 15 number blade. And I'm sorry for that thing, as the intraoperative pick is not available, as at that time I couldn't able to take it. In that case, since my topic is scrapping and slicing method, so what we do basically is we keep this long axis of the blade parallel to the long axis of the gingiva or the gums and the teeth, and just like we peel the skin of the potato or we slice the skin of the potato, similar in yeah. So can you I will be seeing a more clearly follow. See, on the right side, if you are able to visualize, if we compare both the pics, on the right side, before 1 week, when the patient came, this was the hyperpigmented gingiva as it is seen. And post 1 week follow-up, there was a normal pale pink color of the gingiva. The gingiva has returned to its normal color. Now, if we compare the scalpel, yes, is the comparison. I will repeat it again. Can you appreciate on the right side, there is a hyperpigmented gingiva before the procedure, and on the left side, after 1 week follow-up, there was the return of the pink color of the gingiva. So, scalpel is basically a manual or the mechanical modalities, and other modalities are the thermal modalities, as I told you initially in the beginning as well, that we can do it. Now, coming on to the scalpel technique. So, initially, it was first used in the history by Dummett and Bolden in the year 1963. Now, if we compare the advantage and the disadvantage of scalpel. Advantage is it is a simple technique, non-invasive. Non-invasive means as in the sense that it by use of scalpel, you are able, you feel the good tactile sensation, you are able to control the depth. Now it is cost effective and rapid healing do occurs. Healing is good. Disadvantages, since it leaves a raw surface, so it has an unpleasant bleeding chances and higher chances of infection because of the raw surface. Now, if we talk about the bar abrasion method, bar abrasion means we can use either the diamond coated bar or ceramic coated bar too for removal of the gingival depigmentation. It was firstly used in the history by Jinwala in the year 1966. Again, it's simple and safe to perform, and it is economical. But it is a time-taking procedure. Again, we have to be careful to control the depth of deepithelialization because tactile sensation cannot be felt in this case, and more post-operative pain after this modality is there. Now, coming on to the third thermal modality, that is electrosurgery. It was again used by Jinwala in the year 1966. It controls, there's no post-operative, there's no intraoperative bleeding, or it controls the hemorrhage. Yes, as compared to the scalpel, this electrosurgery modality, it permits the adequate contouring of the tissue. Means if you compare this, if you want to do the contouring in the later cases, either with the scalpel or the electrosurgery, then we can say electrosurgery is the best option as it maintains the contouring of the tissue. And yes, electrosurgery during the procedure has less discomfort to the patient. Now, disadvantage is, if we talk about the disadvantage, it is a technique sensitive procedure. Yes, since we are using the thermal modality, so we need to be careful. Undesired tissue destruction can do occur, and sometimes it is uncomfortable to the patient. You always have to use the suction along with it to prevent the foul odor from it. Now, if we use the cryosurgery, that is, we are deepithelizing the epithelium by means of the cooling effect. So it was firstly used in the history by Tal in the year 1987. Advantage can be easy. Yes, it also does not cause the bleeding. This highly specialized equipment is required. Now coming on to today's modern modality, that is the laser. So laser was used by Twells in the year 1992. It creates a bloodless field. Of course, it has the sterilization effect. It reduces the mechanical trauma and reduces the intraoperative pain, but healing is delayed as compared to the scalpel. So hereby, an important points to be concluded over the scalpel versus other treatment modalities. Number one, a cut is a cut, whether it is by the scalpel or the other thermal modalities. Administration of local anesthesia is a must. You cannot say if we are using scalpel, then only local anesthesia is needed. No, it is not the fact. A cut is a cut, again I'm saying, and if it is a thermal modality, then you too also need the local anesthesia, and local anesthesia must be given before any procedure. Now, second thing, healing of these thermal modalities as compared to the scalpel is delayed because, ma'am, please, ma'am, back slide. Healing as compared to the other treatment modalities is delayed as compared to scalpel because in other treatment modalities, the healing occurs by secondary intention as compared to the scalpel in which the healing occurs by primary intention. And yes, the third most important thing to be kept in mind over these modalities is while using thermal modalities as compared to scalpel, be very careful while using thermal modalities because since tactile sensation is not felt in these modalities. So a thermal it can go more deeper without it and can severely damage the tissue. It's like you're cutting a butter with a hot knife. So be careful while using these thermal modalities. Now coming on to the repigmentation. Next slide. Repigmentation. It means suppose we have done the depigmentation, then depigmentation is a procedure, I totally agree, which can be able to revert the normal color of the tissue. But to some extent, The depigmentation hyperpigmented. And this repigmentation is mainly not sure why it occurs, not had been proven, but yeah, to some extent, like Pearl Mutter in the year 1980 has shown two repigmentation cases in which he cooperated that as per the migration theory, in which active melanocytes from the adjacent pigment tissue migrate to the treated area and causes repigmentation of the gingiva. And again, this repigmentation depends secondly upon the clinical expertise and the technique. What technique you have done for what type of case. Again, in that case also the higher chance of repigmentation is there. Now, on the concluding part, conclusion part, we like to present that gingival depigmentation is one of the cosmetic treatment modality in the field of periodontology through which a person can get their confidence back and escape from the social embarrassing. But the success of depigmentation procedure depends upon the time taken for the reappearance of the pigment, and hence prolonged follow-up is necessary. Now here I would like to explain that in my case, the case which I had shown, I did the follow-up after 1 week, but I couldn't appreciate the repigmentation because I couldn't be able to do the further follow-ups. So I cannot say whether my procedure was completely successful or not. Moreover, it's overall necessary that a human being must take care of herself, whether it is of an aesthetic concern or a clinical concern, because that taking of care of herself builds up a confidence within her so that the person can shine throughout. Thank you so much. That's all about my case.
I'm Dr. Asya Hafiz from Sir Syed Medical College, Pakistan, Karachi, Pakistan. And today I'm going to present my topic that a study was conducted in our hospital with the title of Comparison of Efficacy and Safety of 40% Glycolic Acid and 60% Lactic Acid Chemical Peel in Epidermal Melasma. As we all know that melasma is an acquired hyperpigmentary disorder that is further divided into 3 types: the epidermal type, dermal type, and then mixed type, in which both the dermal and epidermal content is found. Then it clinically presents with the light to darker brown macules and patches according to the depth and type of melasma. And females are more prone to have melasma, and the skin type that are more prone to get it are Fitzpatrick skin 4 to 6. And the part that are sun-exposed parts are mostly involved in this disease. And the most frequent parts that get involved in it are the upper lip, central part of our face, that is upper lip, cheeks, and forehead. There are multiple factors that are involved in the pathogenesis of this disease. The most common one are genetic and racial, as we already discussed. The skin type Fitzpatrick 3 to 6, they are mostly involved in it. And then sun exposure has its role with activation of fibroblast and stem cell factor release, and they lead to melanin synthesis. Same like the oral contraceptive pills and pregnancy, they also contribute in the pathogenesis, and multiple drugs and then thyroid dysfunction also involved in it. The main mechanism and pathogenesis in this disease are they lead to all of these factors leads to fibroblast activation and upregulation of the stem cell factors. And then they activate the melanocytes and leads to deposition of the melanin into the dermis and epidermis, and accordingly we divide it into epidermal, dermal, and mixed type. As a name mentioned it, that epidermal, they are limited to the dermis, and dermal, the dermal melanophages, they are rich in the melanin, and mixed type, they have the both type of epidermal and dermal content will be present in the mixed type. The centrofacial, and then clinically we divided into centrofacial, malar, and mandibular. The centrofacial indicates the central part of the face is mostly involved, and this is the most frequent type of clinical pattern of the melasma that is being seen in the patient. And the second one is malar, that affect the malar aspect, and then the least one is mandibular. So previously we used mostly the sunscreen and some lightening agent for the treatment of melasma, but as a well-known hydroquinone, retinoic acid, kojic acid, azelaic acid, still we are using them in the clinic, but now we have new agents for the treatment of melasma. So glycolic acid was also well known and is well known agent for the used as a topical application, and also for the peeling agent. According to its depth, we use it, the percentage we use it as a medium peel and a superficial peel. But the lactic acid is a newer agent that we used in our study and compared it with the glycolic acid for just for epidermal melasma. So objective of our study was to compare the efficacy and safety of 40% strength of glycolic acid and 60% strength of lactic acid chemical peel just in epidermal melasma. And we considered efficacy, the positive efficacy for those agents only who showed the more than 50% reduction in MASI score, that is melasma area severity index score, at 6 months from baseline. We compared it from baseline. The patient who showed more than 50% reduction in MASI score, we considered them the drug is efficacious in those. And the safety was calculated by seeing the frequency of different side effects in throughout the treatment session and even on follow-ups. So this is the score that we used for calculating the melasma severity index. And in this, if you see the 0.3, every part of the face have different constant. For the face, we use 0.3, the constant was 0.3, same for the right malar, and then for left malar, again, 0.3 is a constant. And for central part of the face, that for the cheeks, we use 0.1. So as the area was graded, if you can see, from 0 to 5 according to percentage of the face that was surface area of the face that was involved. And same the darkness and homogeneity, that is darkness, D stands for darkness, and homogeneity was graded from 0 to 4 according to their severity. So the study our study was comparative interventional study and conducted in New Hospital, Lahore, Pakistan. Total number of patients that were taken in our study were 112, and we randomly divide the patients into 2 groups by lottery method in group A and group B. Group A was treated with 40% glycolic acid peel, and group B was treated with 60% lactic acid peel. And the patient who were included in our study were the patient with Fitch-Spectic skin type 4 and 5. And age group that was taken in the study was from 18 to 40 years. Epidermal type of melasma was taken, and we examined the melasma patient under the Woods light to divide them into epidermal and dermal type before taking in our study. And the patient who were not on any type of melasma treatment in last 4 weeks, they were included in the study. And the patient who were not taken in the study were those with the patient who are pregnant, lactating women, or women who are on oral contraceptive pills, or any other systemic retinoids for other diseases. Same, the patient with thyroid dysfunction, they were excluded. Hemoglobin less than 10 gram per deciliter, the patient with the anemia or less hemoglobin, they were excluded. The patient with active infection at the site of treatment or keloid or hypertrophic scar tendency, they were also excluded. And same, the photosensitive disorders at the site of melasma, those patients were not included in the study. So after taking informed consent and history and examination and lab tests were conducted, the baselines of laboratory tests were conducted in the patient, and also to excluding the thyroid and dysfunction and anemia. We took the photographs and the baseline and then started the session. And these sessions were conducted after every 4-week intervals. Total 6 sessions were being done on each patient, and then the patient would the follow-up were done up to the 8 weeks after last session. So we assess our drug by using the MASI score and change in that MASI score from the baseline. If no change in the MASI score was seen, it was considered as no response. And if the patient showed less than 25% reduction in the MASI score from baseline, it was considered as mild response. Same like between 25 to 49% considered as moderate response, 50 to 75% good response, and more than 75% reduction was considered as very good response. In our study, the mean age of patient in both group was 29.61, and the total number of Fitzpatrick skin type in 4, it was 40 in both groups, and Fitzpatrick skin type were 16 in both groups. So this is the chart that is showing the more clinical type of melasma that were seen in these patients. And both the centrofacial pattern was seen more frequently. That was seen in 42 patients in lactic acid and 37 in the lactic acid. And second common that was seen in malar type pattern. That was seen in 14 patients in lactic acid and 19 patients in glycolic acid group. Now, the before and after change in the MASI score was calculated. In group A, that was treated with glycolic acid peel. The mean MASI score at the before starting the session was 10.44, and that was reduced after the treatment to 5.38. Same in lactic acid group, the mean MASI score in the patient was 10.15 before starting the session, and after doing all the session, it will reduce to 5.1. So in both, there is significant reduction in the MASI score, but in between both groups, this difference is insignificant, 5.382. So both are considered as efficacious. Like lactic acid, in lactic acid, there was 54.46% reduction in MASI score, and glycolic acid group, it was 50.56 reduction in MASI score. So same like we, again, we compare and see the responses, how many patients gave you no response and how many mild. So in lactic acid group, the mostly patient gave moderate response to good response. So it was again considered as efficacious. Total percentage of the patient that gave show the efficacy for that drug was 67.9% in glycolic acid group, and 80.4% patient respond to group B drug, that was lactic acid peel. So it's a significant difference here. And the safety was seen by calculating the number of side effects that were seen during the sessions and after the completion of the session. And the number of side effects that were seen in glycolic acid group was 52. And these included hyperpigmentation after the session, hypopigmentation, scarring, and then superadded bacterial infections. In group B, that was treated with lactic acid, the total number of side effects that were seen in all the patients was 29. So on the safety basis, there is a significant difference between lactic acid and glycolic acid, and lactic acid was considered more safer as compared to glycolic. The one of my patient that that was treated with 60% lactic acid group with the result before and after results. We compare with our study with other lactic acid group. The study has been conducted by Sharik et al. In 2005, and they used 92% lactic acid for the pigmentation, and the reduction in the MASI score they seen in their patient was 56%. So our results are very close to them. And same, they conducted study in 2006 with the 92% lactic acid along with Jasner solution, and there was again a significant improvement in pigmentation was seen in both groups. So the conclusion of our study was both the lactic acid, 60% lactic acid and 40% glycolic acid chemical peels, they are effective. But the lactic acid is more effective and safe as compared to the 40% glycolic acid. Thank you.
Hello, everybody. So I'm Dr. Al-Susi, and it's a privilege for me to be presenting here today and listening to all your interesting presentations. I know it's been a long day, so I'll try to make it short and smooth. Okay, today I'll be talking about a case I encountered during my plastic surgery rotation at Saudi German Hospital in Dubai. It is a rare complication of a hybrid breast augmentation, so we thought we should publish it to raise awareness. Okay, so a quick introduction so we're all on the same page. As most of you know, generally speaking, there are 3 ways in which you can get a breast augmented. The most common one is via implants, which come in different types like saline, silicone, and they also come in different textures like smooth, micro-textured, different sizes measured in cc's. The second way is via fat transfer, which is collected through a liposuction from either the abdomen, flanks, or the arms, or all of them. And finally, there's the hybrid method, which is a combination of the 2 above. Okay, so generally, the augmentation procedure can come with complications, such as pain in the augmented breast, changes in sensation like numbness or loss of sensitivity, infection, changes in the position of the implant. And further in the long term, you can also get an implant leakage or even rupture. And there's also capsular contracture, which leads to a malformation in the shape of the breast. Okay, so the case is as follows. We have a 28-year-old female who presented to the ER with severe pain in the right breast region. There's also swelling and shape changes for 2 weeks. She has no other symptoms, but states that she had a hybrid breast augmentation 24 days ago, and also a periareolar breast lift, all done in a different hospital. Her fat was harvested from the abdomen, flanks, and arms. She denied any chronic diseases, allergies, or other surgeries. When we examined her, we found asymmetry showing a larger right breast and also a purulent discharge from the inframammary incision. Unfortunately, further details and operative notes could not be retrieved from the other hospital, so we had to work with what we had. Yeah, and so here, this is the photo of the breast. So you can see clearly the swelling of that breast, and you can also see the pus here coming out of the inframammary incision. Okay, so our preliminary diagnosis was breast implant infection. We immediately admitted her and started her on IV cefazoline. And then we consented her for urgent surgery. We had to make sure she was aware that there will be gross asymmetry after taking out her implant, and that she will have to undergo another surgery for resymmetrization and cosmetic purposes. We also had to make sure that she's aware that this surgery could be life-saving for her. So yeah, in the surgery, we made our incisions in the lines of the scar, and we took out the implant and did a washout with a triple antibiotic solution. Okay, so this is the image here of the implant, which it turned out to be silicone-based, round, micro-textured, and was located in the subglandular pocket. As you can see, there are needle track marks here. I'm not sure if you can see through my pointer, but these are needle track marks. And in the video, which I unfortunately could not upload, you can also see leakage through micropores, which was probably due to damage from or perforation from the needles, puncturing for the to put in the fats. Okay. I did put in a link though. You can check it out. It's also in the published paper, which I'll give you more details in a few minutes. Okay, so we then closed up the pocket, leaving in a 15 French silicone drain. 2 days later, the patient was discharged with IV and oral antibiotics. And we sent that implant to the pathology lab, and they confirmed the presence of fat cells. 2 weeks later, we called her in, and her suture lines were clear without any signs of infection, and the inflammation had gone down significantly. And this is what her breasts looked like 5 months later after she had undergone resymmetrization by her original doctor, which I'm assuming was done for free. Finally, our senior surgeon, our expert surgeon, gave some recommendations in the paper to avoid such a complication. Number one was to transfer the fat before inserting the implant, if possible. And number two, placing the implant in the dual or submuscular plane. Number three, if fat transfer is not possible before implant insertion, we can insert a sizer, then transfer the fat, and finally replace the sizer with the true implant. Number four, when transferring the fat, the patient should be sat at 45 degrees to better visualize the borders of the implant. And also the assistants in the surgery can help by pushing away or down the implant to avoid puncturing it. 5, injecting the fat subcutaneously and not deep or perpendicularly. Again, the cannula should be inserted parallel to the implant and not perpendicularly. And you should use a 16 or 18 gauge blunt cannula and inject the fat in a retrograde fashion, so inject it as you're pulling out. And try using when using a finer cannula, you will increase the chances of perforation, so avoid using them. And you can also use intraoperative ultrasound when injecting to assist in avoiding the implant. So yeah, this is our paper. It was published in the Annals of Plastic and Reconstructive Surgery. So feel free to have a read and check out the video. The link to the video is attached there. Yeah, that's basically it. Thank you all for listening and your attention, and I'm very happy to be taking